My name is Carlos, and today I'm going to be demonstrating how to insert an NG tube, how to do tube feedings, and how to remove the NG tube. I'm going to start by inserting it. So the first thing I'm going to do is walk into the patient's room, introduce myself, verify the physician's order, and verify my patient's identity by their wristband. After that, I'm going to get my hands washed, some clean gloves donned. For demonstration purposes, I'm not going to put them on because these are too small for me. I'm going to get my equipment ready, get it opened. I'm going to get something draped across my patient's chest, have them up in a high Fowler's position. I'm going to have an emesis basin ready for them just in case, have some ice chips or water for them, and then I can grab my NG tube, get it out of the packet. First, I'm going to verify which nostril I'm going to use by occluding both sides and having them blow, so make sure which nostril I'm going to use. Then I can get my NG tube and measure from the tip of the nose to the earlobe, and then from the earlobe down to the xiphoid process, and that's how far I'll insert the NG tube. So for this one, I'm going to insert it down to 48. I'm going to mark that off with some tape. I'm going to get some lubricant and lubricant to 3 to 4 inches of the NG tube. I'm going to have my ice chips for my patient. I'm going to have them tilt their chin to their chest, and then I can start inserting the NG tube. So I'm going to grab that, and then I'm going to start inserting through the nostril. I'm going to have the patient swallow. As I'm inserting, have some ice chips in their mouth to lubricate their throat. If I see any signs of complications such as shortness of breath, cyanosis, or bleeding, I'm going to immediately stop and pull the NG tube back out. For demonstration purposes, I'm going to stop right here because the NG tube won't go any further. I'm going to have it clamped. I'm going to get my syringe, and I'm going to hook it up and check placement by pulling out gastric contents and verifying the pH with some pH strips. I'm going to then replace that content and clamp my tube. If I were to have any continuous feedings, if there was an order to hook it up to suction, or if just a clamp, I would do that at this time. I can then get some tape it to my patient's nose. I would ask the patient if they're experiencing any complications, if they're comfortable, if they're experiencing any nausea. And then I can get my NG tube clamped to their shirt. I can remove the drape. And then I can take off my gloves, wash my hands, and document any complications and gastric contents and get all that documented. After this, I'm going to do the feedings. So start from the beginning. I would introduce myself, verify my physician's order, and verify my patient's identity by their wristband. I already have their NG tube in place, so I can get something draped across their chest, get that ready. Have them in a semi-Fowler's to high Fowler's position. I'm going to wash my hands, don some clean gloves, and get my equipment ready. And get my formula, shake it up, make sure that's shaken up very well. If this was a continuous feeding, I would get my formula, pour it into a bag, prime my tubing, and then hook it up to a pump and verify that all the settings are properly inputted into the pump. I can then hook that up. Before doing that, I would want to pull back gastric contents and verify placement, check that residual, test it with a pH strip. If the residual is less than 250, I can replace it back into the patient. If it's over 250 the first time, I'm going to stop, wait an hour, and check again. If it's over 250 again, I'm going to stop the feedings and discard. If it's over 500 the first time, I'm going to do the same thing, stop feedings and discard. So So once I verify that, I can get my continuous feeding hooked up and ready to go. Same thing for an abdominal tube or a peg tube. I'm gonna pull back, check gastric content, check the residual, and do the same thing. With my NG tube, for this demonstration, I'm gonna be doing a bolus feeding. So I'm gonna do the same thing. Put my syringe in, pull back gastric content, test that with a pH strip, check the residual. If it's less than 250, replace. If it's over 500, stop the feeding and discard. I can then take my plunger out, put my syringe in, and pour my feeding in and let it go in by gravity. After I'm through with my feeding, I would want to flush with 30 milliliters of water. Same thing with the continuous feeding. You would want to flush with 30 milliliters of water before and after, and then every 4 to 6 hours after that. So then I can take my syringe out, I can clamp my tube, take this off my patients, document residual input and output, verify that my patient is okay, take my clean gloves off, wash my hands, and then document everything. Next, I'm gonna do the NG tube removal. So I would do the same thing, come back in, introduce myself, verify my physician's order, verify my patient's identity by their wristband. I can then have them up in a high Fowler's position, wash my hands, don some clean gloves. I'm gonna have something draped across their chest. Have an emesis basin ready. If I were to have any continuous feeding or suction hooked up to the NG tube, I would unhook that and clamp it at this time. I'm gonna have my patient tilt their head down, chin to chest, start removing this tape from their nose. And then once I'm ready to remove the NG tube, I'm gonna ask them to hold their breath and bear down as I'm pulling out. I'll count down from 3, 3, 2, 1, start pulling. Once that's out, I'm gonna wrap it up, discard it into a red biohazard bag. I'm gonna verify that my patient is okay, assess for any redness, irritation, bleeding, any complications, do nasal and oral care for my patient. I can then lay them back down. I can take my gloves off, clean my hands, document any complications, and the assessment on my patient.